A very good evening to all of you. Myself, Dr. Prateek Garg, your ENT tutor. We are going to discuss about tumors of larynx. It is very common in nowadays because of the increased habit of smoking or alcohol intake. Now, the first disease which we'll talk about is juvenile papillomas. So basically, juvenile papillomas are the papillomatous growth in the larynx, mainly involving the glottis and supraglottis part and affecting the juvenile age group, that is the young children or infants. So by the name itself suggests these are the papilloma most commonly affecting the infants and the young children, mainly involving the glottis or supraglottis, that is the true and false vocal cords, epiglottis and airy epiglottic fold. Look at the diagram. Suppose this is my true vocal cord shadow. Okay. So I'll just mark the papillomas by the green color. So these papilloma are involving the true vocal cords over the airy epiglottic folds or the false vocal cords, and then over the epiglottis. So these are the juvenile papillomas. These are very friable. I mean, they can detach very easily, and while detaching they will produce lot of bleeding. So these papillomas are very aggressive in nature. Recurrence is very common. Suppose if we do the surgery and remove all the papilloma, within a very short period of the time, baby again will present with the papillomas again infiltrating in the glottis and the supraglottic part. So these papillomas recurrence is very common. Sometimes these papilloma may get fade away when the patient acquires puberty, but again they may reappear spontaneously. It has been seen that human papillomavirus type 6 and 11, they are the major contributing factor for this juvenile papilloma, out of which the human papillomavirus type 11 is more commonly associated with this papilloma as compared with the type 6. So remember this point, it has been asked in the exam. Human papillomavirus type 6 and 11 are associated with juvenile papillomas. What are the symptoms in the patient? Patient will present with the hoarseness of the voice, that is the poor quality of the voice, and if this papilloma they are completely or majority of the airways getting blocked by this papilloma, so patient may have stridor. If we do the laryngoscopic examination, we can see the white or pale, glistening, friable papillomas. These are very friable and generally they bleed. If we remove the papillomas, they bleed too much. So these papilloma are very friable with the bleeding growth. Okay. What is the treatment? Treatment is surgical excision. CO2 laser is considered to be one of the great tools for this papillomas. What is the advantage? Because of the CO2 laser, we can precisely remove the papillomas without affecting the normal laryngeal structure, and plus laser will help in reduced bleeding. So it is most widely used nowadays. After the surgery, we can apply the mitomycin C so that the recurrence will be diminished or decreased. What are the other treatment? Cryotherapy or the microelectrocautery can also be helpful for surgical removal of these juvenile papillomas. Intubation is contraindicated. Why the intubation is contraindicated? Because these papillomas are very friable. If we try to insert the endotracheal tube, these friable papillomas may get detached, leading to the bleeding, and this papilloma may go inside the bronchus. So intubation is contraindicated. For the prevention of the recurrence, there is ABC. So what are the treatment or the medicine used for the prevention of the recurrence? A stands for alpha interferon therapy, B stands for bevacizumab, and the C stands for cidofovir. So ABC is helpful for the prevention of recurrence. Now, next disease is adult onset papillomas. As you can see in the picture, if I mark it by the red color, this is a papilloma shown here. This is an adult onset papilloma. Adult onset papilloma, they are generally not multiple. They are solitary lesion, mostly present at the anterior commissure or anterior part of the vocal cords. They are having less recurrence or no recurrence. Once you excise this papilloma, generally they will not recur. So they are less aggressive. They are less aggressive, does not recur after excision. Males are more commonly affected as compared to female, generally single and usually at the level of the anterior commissure, or we can say anterior half of the vocal cords. And what is the treatment? We can either remove them by the help of the CO2 laser, cryotherapy, by the means of the cauterization, and the best part is they don't recur like the juvenile papillomas. Now we talk about laryngeal carcinoma. Most commonly laryngeal carcinoma patients are male. We know the obvious reason is because of the smoking habits, because of the alcohol intakes, or because of the occupational hazards like the asbestos, mustard gas, or petroleum. The workers working in the petroleum industry, because of the inhalation of the fumes, they may have the increased chances of laryngeal carcinoma. And in cigarette smoke, what is the causative agent? Is the benzopyrene. It is a carcinogenic agent present in the cigarette smoke, and because males are usually smokers, so most of the males they prefer smoking, so that is the reason why it is more common in the males. Histopathology, if we talk about the squamous cell carcinoma variant, is the most common type. Other variants may be the adenocarcinoma, but squamous cell carcinoma is the most common type of the laryngeal carcinoma. Now there are three types of laryngeal carcinoma: supraglottis, glottis, and subglottis. Out of which the most common site is glottis. So the most common site is the glottis, and these glottic carcinoma, these are having the best prognosis out of all three. The reason being because the presentation of the patient will be early, because if there is any lesion in the glottic region, patient will have hoarseness of voice, or patient will have some sort of dyspnea, because the glottic is the narrowest part. So generally the presentation is early, so the patient get treated early. That's why the prognosis is very good. So the most common site is glottis, then comes a supraglottis, and then comes a subglottis. Best prognosis is in glottis, and earliest presentation also is in glottis. Now this is a table just to differentiate between the supraglottis, glottis, and subglottic carcinoma. So we have discussed the glottis carcinoma are the most common. Most commonly the site is at the free edge of the vocal cords. Suppose this is the vocal cord. So the free edge. The carcinoma, the commonly it is present at the free edge of the vocal cords, or the superior surface, the surface facing towards the epiglottis. Mostly the lesions are present at the superior surface or involving the anterior part of the vocal cords. Any carcinoma of the glottis which is involving the posterior part, it is considered to be more dangerous or having the poor prognosis. The reason being, if the carcinoma is present over the posterior part of the glottis or the vocal cords, so that means it is spreading towards the arytenoids or towards the thyroid or cricoid cartilage. Okay. So the glottis carcinoma, mostly at the free edge, generally they have a presentation like a small nodule over the vocal cords, or some sort of ulcer or thickening of the vocal cords. Since vocal cord involvement is early, so patient will have hoarseness of voice or some sort of breathing difficulty. So patient will present to the clinics early. If we talk about supraglottis carcinoma, incidence is intermediate, that is less common than glottis carcinoma but more common than subglottis carcinoma. Most common area involved is the epiglottis. And if we talk about the appearance, if the lesion is suprahyoid, that is above the level of the hyoid, mostly they are exophytic growth. If the lesion is subhyoid, that is below the level of the hyoid in the supraglottic part, the lesion will present like the ulcerative lesion. And in this supraglottic carcinoma, vocal cord involvement is generally very late. So hoarseness of voice will be late and patient will present to the OPD lately. If we talk about subglottic carcinoma, it is least common, most common again in the anterior half, and the presentation will be, there will be submucosal nodule and sometimes ulcers also. Now let's talk about again glottic carcinoma. So glottis carcinoma, generally metastasis is very less frequent or never, because this vocal cords or the glottic part has the least lymphatic drainage or no lymphatic drainage. So that is the region, or that is the advantage. There will be lesser lymphatic involvement, lesser lymphatic spread out. So metastasis will be least common in the glottis carcinoma. If we talk about supraglottic carcinoma, lymphatic metastasis is very early because of the rich lymphatic supply, and there will be bilateral both side lymph nodes will be involved if there is epiglottis carcinoma, because epiglottis is in the midline, so it is draining on both the sides of the lymph nodes. So supraglottis and subglottis, these both are having early bilateral lymph node metastasis, whereas the glottis carcinoma, they are having least or no lymphatic metastasis, and that will make them more or better prognosis in the glottic carcinoma. Now let's talk about symptoms. Glottic carcinoma, hoarseness of voice is present, so patient will present very early, whereas in supraglottis or subglottis, generally they are silent because the presentation will be late. So patient generally, whenever they present to the OPD, already disease has been advanced. Let's talk about the symptoms. What can be the presentation? Patient will have painful swallowing, or we can say dysphagia. Then comes throat pain, ref-word pain in the ear, and sometimes respiratory distress. But these are late manifestations. If we talk about nature, supraglottic carcinoma are generally anaplastic or highly malignant. If we talk about glottis, they are generally well differentiated and less malignant. Subglottic carcinoma, again they are highly malignant. Prognosis, supraglottis, it is bad because presentation to the OPD is late and lymphatic involvement is early. Whereas glottic carcinoma, it is good because presentation is early in the OPD because of the hoarseness of voice, and lymphatic metastasis is lesser, and they are usually well differentiated. So look at the picture of a supraglottic carcinoma. You can see ulcerative type of lesion. Okay. This is a vocal cord carcinoma where you can see the irregular ulcerative type of the vocal cord lesion. These are having best prognosis. If we talk about subglottic carcinoma, you can see a nodule-like mass. Now, what is the treatment of the laryngeal carcinoma? Their options are surgical excision, then comes a radiotherapy, then comes a chemoradiotherapy. And the fourth term is chemoradiation. That is combination of the chemotherapy plus radiotherapy. Generally, the concurrent chemoradiations, they are being reserved for type 3 or type 4 type of the laryngeal carcinoma. So concurrent chemoradiation is preferred in the stage 3 or 4, and the drug which we use is the cisplatin and the carboplatin. So let's talk about total laryngectomy indications, where we completely excise the larynx. So indications are either the stage T3 and T4. It is very important, asked multiple times in the exam, what are the indications of the total laryngectomy. So if the patient is in advanced stage of the laryngeal cancer, that is a T3 and the T4 stage, or suppose the vocal cord are fixed, mobility is hampered, then again we have to do the total laryngectomy. If there is involvement of the thyroid or cricoid cartilage with the perigontritis, that is the pain if you touch the thyroid cartilage. So cartilage is involved, then again total laryngectomy. If there is bilateral arytenoid involvement of the posterior part of the vocal cords or posterior commissure, that means the lesion being extended to the arytenoid or the cricoid cartilage. So in that case also, we will prefer doing the total laryngectomy. And what are the other indications? Transglottic cancer or distant metastasis or the cervical metastasis. What is the contraindication of the total laryngectomy? See, if there is cervical metastasis, we will go for the total laryngectomy. If there is distant metastasis, that means the disease has already been very advanced. So in that case, surgery will not be very helpful. So what we will prefer is the chemoradiotherapy. That is a combination of the chemotherapy plus radiotherapy. Now let's talk about individual lesion. Suppose there is carcinoma in situ. In that case, we can use the CO2 laser. So by means of CO2 laser, if there is carcinoma in situ, so we can excise the lesion by the CO2 laser. If there is T1 or T2 carcinoma, so what are the preferred modalities? Is the radiotherapy or partial laryngectomy. And if there is T3 or the T4 carcinoma, so T3 or T4, in both the cases, what we will do is a total laryngectomy followed by radiotherapy. If patient is not interested for the surgery, then what we can advise is the concurrent chemo radiations. Otherwise, we can do the total laryngectomy followed by radiotherapy. The drugs used are like cisplatin, fluorouracil, carboplatin, etc. In T4 carcinoma, again, total laryngectomy followed by radiotherapy. If there are heavy patient is having more advanced lesion, that is the distance metastasis, in that case surgery is not helpful. So what we can do is chemo radiation. Now, certain important point, radiotherapy is curative in early vocal cord lesion, that is a T1 or T2 stage with the normal mobility. The vocal cord should be mobile. In that case, if we do the radiotherapy alone, that is also curative in 90% of the patients. Now, toluidine blue, it is one of the solution which is helpful in differentiating carcinoma in situ and the leukoplakia. Okay. Now, just try to remember one point, aspiration. Patient can aspirate anything into the larynx. So, aspiration is prevented by the epiglottis, and other one is the cuff reflex. So, if we want to do any surgery where we have to remove the epiglottis, so just have a look at the cuff reflex, because if cuff reflex is also diminished in this patient, so if we remove the epiglottis, so there will be more and more chances of aspiration. So, before removing epiglottis, cuff reflex should be normal. And suppose if you have done the total laryngectomy, so what are the recent advances doing the vocal rehabilitation? The first one is the esophageal speech, where we can use the esophagus for producing the speech. Then comes the tracheoesophageal speech. It is considered to be the best. And there are other options like the artificial larynx, like the electrolarynx or transoral pneumatic devices. These are certain recent advances.